I want to talk about how we make things a little bit better. But to make things better, we need to understand what the difficulties are in the first place. And to start off, I'm going to start with a contrast. I'm going to start with 50 years of technological advance. 50 years in which the world of medicine has moved forward so much, and there have been in that time so many developments that have changed the world. Let's just look at a few of them. Heart transplants, vaccinations, the eradication of smallpox, test tube babies, the characterization and treatment of HIV, clot-busting drugs, MRI scanners, the Human Genome Project, stem cell therapy, and of course the digital revolution. How can we go so far and yet in terms of constipation, IBS, it feels like we haven't made any progress at all. So, of course, that leads to the sorts of things that Virginia's been saying. The treatments don't work. It took years to get a diagnosis. No one can explain it to me. No one seems interested. Why can't they see how severe this is? I feel blamed. I don't feel believed. So for the next 5 or 6 minutes, I want to try and give you a sense of where the problems are. Why is it so difficult? Why don't we understand functional gut disorders? And the first problem is that we're not all the same. In this slide, there are patients with chronic constipation, and they will all have the same sort of symptoms. They will not go to the toilet frequently enough, and they will strain, and they will have pain, and they will feel bloated, and they will have wind, and the symptoms are the same. And the label is the same. They might be labeled as IBS-C or functional constipation. But the actual underlying illness, the physiology that's causing the illness, is likely to be different. But it's actually more complex than that. And I think of it as a sort of a mosaic where there are a whole range of physiological abnormalities. And this isn't proven, by the way. This is just a way that I conceptualize the illness, and others may have other ways. And some of these, we know that all of these problems like slow transit and abnormal gut bacteria and immune activation, structural problems of the pelvis, absorption and secretion problems, we know that they're all relevant, but not necessarily relevant in the same patient. So a patient may have a handful of these. Let's just have a look at a few in detail. Let's start with the peristalsis, the movement of the bowel, the serial contraction of muscles to push things around. We know that some patients with constipation have an absent peristalsis or very weak peristalsis. But to understand that, we need to understand two things: either the muscles or the nerves and the wall of the bowel, or the nervous system that controls that bowel, the autonomic nervous system. So what about these muscles and nerves? Well, they sit on the outside of the bowel, well away from any bit that we can pick off with an endoscope. In order to get bits of this tissue to look at and study, we have to do a full thickness biopsy. We have to make a hole in the bowel. That requires an operation. It can cause chronic pain. It can cause adhesions. It can cause worse complications. And because of all of that, we don't do it. So we can't tell you in most cases whether there is a problem there. When we do have bits of bowel from patients, we study these, and in about half of them there are problems there. There are muscle problems. Frustratingly, all the muscle problems look different. And then there are nerve problems, and there are different types of nerve problems, and then there are people with normal muscles and nerves. So there's a whole range of abnormalities, but I can't tell you what's going on in your bowel. And then there's the autonomic nervous system, and Adam Farmer will be speaking later today, and Adam's done some brilliant research that's recently been published, showing that there are likely to be abnormalities of the autonomic nervous system in functional gut disorders. But if you look at the data, there are some patients that have these abnormalities and some that don't, and the symptoms don't tell us who has them and who doesn't. And the tests that are required to study this are invasive and take a long time and can't be used in clinical practice. So that's another thing which you might have, which I can't be certain that you do. Adam will also be talking about pain and pain pathways, and he'll no doubt mention the issue of sensitization and amplification of pain. And this doesn't just happen to different extents in different people, it happens to different extents in different bits of your bowel. So one bit might be affected more than another, but it's really difficult to study. We can't do that in a clinical situation. So we can't tell you precisely what's going on inside. But there are tests we can do in clinical practice, and I'm afraid to say that many of you will have had this test, a defecating proctogram. And this image shows the rectum emptying through the anal canal here, but there is a problem. There's a pouch in the front there going into the back of the vagina, and that's taking the fecal stream away from the anal canal and pushing into the back of the vagina. And that fits with what the patient's symptoms are like. So surely this is a case where we can understand something. But even that's not quite straightforward, because actually if you look at women over the age of 30 who don't have constipation, who don't have evacuatory problems, about 70% of them have these pouches, which we call rectoceles. So what is it about this one that makes it give you symptoms? And that we don't understand. And I could talk about all these other issues up here and give you the same story. We understand that they're relevant to the illness as a whole, but we're not sure whether they're relevant in you as an individual. And that causes problems. So these two individuals that come to my clinic one after another may have similar symptoms, but they may have completely different physiology. They'll respond to different treatments, but I can't see that, I can't predict that, and I can't explain specifically what the problem is. And the inability to predict effective treatments is a problem. It means that you end up going round and round in circles, and many of you have tried many different treatments. It also means that any single treatment is only going to be effective in a small proportion of patients if everyone's different underneath. And that creates a whole host of additional problems. It creates problems for licensing authorities, and if a drug is only helpful in 20% of patients, is that a useful drug to license? It causes problems for the pharmaceutical companies in terms of developing these drugs. So we have a difficulty with clear understanding, we have a difficulty with effective treatments. But that's not where it ends, because as Virginia has said, there are problems with perceptions as well, and there are problems with resources. We've talked about the poor understanding, and the discussion that I've had so far is a relatively enlightened discussion. So the experts here in the room will understand what I'm talking about. But much of the data that particularly Adam's going to present is quite new and won't be available yet to your GPs and generalists. So there's a poor understanding, and the treatments have been limited. But also there's no diagnostic test. So that means that a general doctor who's not an expert in the field doesn't have the confidence to make a diagnosis. And that means that these doctors are left unsure, uncertain, sometimes bewildered, sometimes lost. Possibly not disinterested in you as a person, but unable to help. And there is a sort of Cinderella status of the illness as well. A sense that it's not so important. And part of that, I think, comes from the fact that although most people who are patients in this room will have severe, life-changing symptoms, this is an illness that's really common. And for most people, this illness is relatively mild and it's manageable. So it gets a reputation for being mild and manageable. What we need almost is a sort of different name for patients with the severe form. And that difficulty of recognizing severity is made worse by the fact that there's no objective measure of severity. So if you had Crohn's disease, we would look inside your bowel and measure the size of the ulcers and the depth of the ulcers. If you had liver disease, we would do blood tests and see how bad the condition was. But we can't do that with this condition. And the fact that nobody dies from it is a good thing, but it does mean that the funders and commissioners, when they're putting it up against things like cancer and heart disease, find that this becomes less important. And Virginia has already talked about the fact that this is not easy to talk about. There are patient support and lobby groups, I think for almost every disease, but I don't know one for constipation. And June Rogers is going to talk a bit later about how we can mobilize ourselves as patient groups to help with this. But that does mean that our resources are limited and research funding is limited compared to the size of the problem. But also perceptions in society are affected as well. So that your family may not understand, your employer may not understand, the authorities don't understand with things like disability living allowance. And that leaves you feeling isolated and alone. So we are in a bit of a tight spot. And I think there is a way forward. And the way forward starts with having a specialist service that focuses on the condition, that brings people together, and that puts a spotlight on this problem. And we can't centre our service around a physical thing, like a dialysis unit in a kidney centre or a coronary care unit, nor a type of treatment. We centre our service around a set of core values. And around those core values, we use them to drive the activity and performance of our multidisciplinary team. And we have that team embedded in a service that works for all our stakeholders and also involves research. So what are those values? Well, we have a set of 4 values that we've had for 4 or 5 years now. They're owned by all the staff. Everyone who's employed in our service has a job description with these values on them. They might change after today because they've never been vetted by a patient group. So they are this. We want a patient-centred service. We want to engage and listen. That's what today is all about. Respect and validate, thoroughness of assessment and explanation. If I can't cure you, at least I can spend some time trying to explain why you feel like this. Innovation, we want to develop new treatments, and we are. We want to assess new treatments, and we do a lot of that. But we also want to innovate our service. We want to change for the better, continually improving. And evidence-based, but knowing where that evidence is weak. And the team are virtually all here today, and you'll meet most of them. They're physicians and surgeons, some of which specialise solely in this condition. Nurses that don't just do nursing, but are multi-talented, and they do holistic things as well. And I've realised that they're brilliant at organising conferences as well. Specialist dietitians who have organised your lunch today and are in the room as well. Virginia, who you've met, who we couldn't do without now. Caroline, a psychotherapist. Donna, a holistic therapist. Adrian, our physicist. Our brilliant research staff. And the community team, which are really important to us because we want to work across the hospital and community barrier. And as Virginia says, this team allows us to offer a whole range of treatments. So not just drug treatments, but biofeedback and rectal irrigation and low FODMAP diets and nurse-based holistic therapies and specialist holistic therapies, psychotherapy, specialist surgery and research-based therapies. But we don't just offer, some of these you don't get in many other places. So we offer treatments that you might not get elsewhere. But we also do something else that's slightly different. We're willing to give treatments together at the same time. Where things are difficult, maybe they're difficult because you've got more than one physiological process driving the illness. Surely that needs more than one treatment at the same time to make things better. The whole is greater than the sum of the parts, and treatment needs to be holistic. And this afternoon, those of you coming to my service redesign, one of the things we want to be talking about is how we change our service in the future, and one of the key areas is getting our service out into the community. So not just having these specialist treatments that we do, they're specialist treatments, but they're actually not difficult treatments, and there's no reason why people in primary care in the community should be getting them as well. So we're about to employ a nurse who will work both in the hospital and in the community. We are having GPs come into our clinics to do preceptorship. We want to design a post for a special interest GP, and we actually are starting negotiations for our team to go out and work in GP surgeries. And there are new treatments coming, and Anton's going to be talking about these next. We are in a very exciting time. We're having at least one new treatment a year coming online, being licensed since about 3 or 4 years ago. And there are a whole range of treatments coming through as research-based treatments. So it's a really positive time. We've got a service with based on some key values. We've got a multidisciplinary team that is very engaged and dynamic. We've got new treatments in the pipeline. But that isn't enough. We want our service still to be better. We want our service to change, and that's what this afternoon is about. We want to hear from you about how we can best design our service, what priorities you have for our research, and how you feel about your illness. And as has already been said, it's really important that we raise the profile of this illness. And June's going to be talking a little bit about that later today and helping you to do that. Thank you very much.